Welcome. In this session, we are going to talk about orbital infections. And orbital infections are important to diagnose rapidly and treat promptly because of their associated severe morbidity with possible mortality. Bacterial orbital infection or cellulitis is the most common cause of orbital infection, and the orbit can get infected from direct spread from adjacent tissues, out of which sinus is the most important. So apart from sinusitis, orbital infection can arise from dacrocystitis, dacroadenitis of the lacrimal gland, panophthalmitis, and odontogenic infection from teeth. Hematologic spread from distant sites of infection such as otitis media, pneumonia, and endocarditis can also involve the orbit, and trauma or infection of the overlying skin can also involve the underlying orbit. For cultures of the organism involved in orbital infection, material should be taken from the ostia of infected sinuses or abscesses. It is important to remember that conjunctival swabs and blood cultures, particularly from afebrile patients, are rarely helpful. Now, according to the location of the tissues involved, bacterial infection of the orbit can be divided into preseptal cellulitis and postseptal or orbital cellulitis, and they have differences in their management and prognosis. Preseptal cellulitis is the involvement of tissues in front of the orbital septum, and it presents with pain, eyelid edema, and erythema. So we see a patient of preseptal cellulitis in the left orbit in this picture. However, edema can spread to the forehead and to the contralateral eyelid through the tissue spaces. Elderly individuals may have atypical presentation with less symptoms and late presentation with tissue devitalization requiring debridement. And unlike orbital cellulitis, the following are absent: displacement of the eye, restriction of ocular movement, blurring of vision, pupillary reaction, pain on eye movement, and chemosis. And this cluster of signs are very important to differentiate between preseptal cellulitis and orbital cellulitis. The sources of preseptal cellulitis is usually the adjacent sinuses in children or dacrocystitis and trauma in adults. So sinusitis can cause both preseptal and orbital cellulitis, as we will come to later. And most cases of preseptal cellulitis are due to gram-positive cocci, and Staphylococcus aureus is almost always the causative organism in preseptal cellulitis following trauma. Infections with methicillin-resistant Staphylococcus aureus usually have more pain, a greater tendency to abscess formation, and tendency to involve adjacent tissues such as the orbit, the globe, and the cavernous sinus. And H. influenzae B is still found as a causative organism in preseptal cellulitis in young children. Imaging is required in preseptal cellulitis if lid swelling precludes assessment of ocular movement, and imaging can detect involvement of the sinus as well as spread to the orbit. So this is a CT scan of a patient with preseptal cellulitis originating from an infected lacrimal gland. Oral antibiotics, particularly a combination of amoxicillin and clavulanic acid, suffice in most situations. However, intravenous antibiotics such as ceftriaxone and vancomycin is indicated in infants with preseptal cellulitis when there is no improvement with oral antibiotics after 48 hours, spread of infection to the orbit, and the possibility that the patient will not be able to follow up regularly. In addition, warm compresses, nasal decongestants for sinusitis can be instituted, and if there is an abscess formation, surgical drainage of the abscess is required for resolution of the infection. And for surgical drainage of a preseptal abscess, it is very important to remember that the orbital septum should not be breached during drainage of the abscess, else infection will spread into the orbit and the levator palpebrae superioris muscle may be injured. The second form of bacterial infection of the orbit is orbital cellulitis, and it involves tissues posterior to the orbital septum. And most orbital cellulitis originate from sinusitis in adjacent sinuses, most commonly the ethmoid sinus, particularly in children. And in contrast to preseptal cellulitis, which is almost always due to gram-positive cocci, organisms causing orbital cellulitis may be anaerobes as well as gram-positive cocci. And it is known that orbital cellulitis due to methicillin-resistant Staphylococcus aureus can occur without an antecedent sinusitis, can have multiple abscesses, have more tendency to involve adjacent tissues causing more morbidity, and requires drainage more often. Orbital cellulitis in children is usually caused by a single gram-positive bacteria and thus responds well to antibiotics and are less likely to need surgical drainage. However, in adults, orbital cellulitis can be polymicrobial and are more likely to require surgical drainage. And this is important to remember in planning our approach to management of orbital cellulitis in children and adults. Clinical features of orbital cellulitis include systemic signs such as fever and leukocytosis, pain particularly on eye movements, chemosis, ptosis and proptosis, as well as a restriction of ocular movements compared to the contralateral eye. And there can also be signs of optic nerve dysfunction with blurring of vision, relative afferent pupillary defect, impaired color vision and visual field defects. And signs of optic nerve dysfunction demands urgent institution of treatment. So these are all signs of orbital cellulitis not found in preseptal cellulitis, making them very important in differentiating the two entities as we had discussed. Orbital cellulitis has significant morbidity and thus requires urgent institution of treatment. In a patient with orbital cellulitis, development of cavernous sinus thrombosis is indicated by an increase in proptosis and ophthalmoplegia ipsilaterally, and the ophthalmoplegia, that is restriction of eye movement, becomes out of proportion to the degree of proptosis. There will be loss of sensation in the territories of the first and second division of the trigeminal nerve, as a result of which there will be a decrease in tenderness and pain on eye movements from orbital cellulitis. And one important clinical feature of cavernous sinus thrombosis is contralateral ophthalmoplegia, because the cavernous sinuses of either side are connected by venous channels. So the infection can spread from ipsilateral cavernous sinus to the contralateral cavernous sinus, causing thrombosis of the contralateral cavernous sinus. Other orbital contents can also be involved in orbital cellulitis, resulting in secondary glaucoma, retinal venous occlusions, retinal arterial occlusions, endophthalmitis and panophthalmitis in the eye, infectious optic neuritis and cranial neuropathies. Further spread results in meningitis and brain abscess when we will find leukocytosis in the CSF, and in this situation CSF will also be able to reveal the causative organism. And because of these significant complications, orbital cellulitis, if untreated, can result in mortality also. Orbital cellulitis may result in abscess formation, and this can require surgical drainage. And the abscess is usually subperiosteal in location adjacent to the involved sinus. And from the subperiosteal location, the abscess may also spread through the periosteum into the orbit. In this picture, we see a CT scan revealing an abscess in the medial orbital wall adjacent to ethmoid sinusitis. And the left ethmoid sinus is clear. The abscess formation is suggested by progressive globe displacement and lack of response to antibiotic therapy. And it is known that subperiosteal abscesses in the medial orbital wall in children may be sterile. And there is a long list of conditions which are indications for drainage of abscess. And this include age of the patient more than 9 years, abscess located in an orbital wall other than the medial orbital wall or located inside the orbit requires drainage, and an intraconal abscess within the orbit requires urgent drainage. A large subperiosteal abscess should also be drained. If a subperiosteal abscess does not respond to IV antibiotics 24 to 48 hours after institution of treatment, suspicion of anaerobic infection from infection of the tooth, or CT scan revealing gas inside the abscess. And other indications for drainage of abscess include frontal sinusitis, chronic sinusitis with nasal polyps, acute optic nerve or retinal compromise, and recurrence of the subperiosteal abscess after drainage. In orbital cellulitis, imaging with CT scan can show orbital involvement adjacent sinusitis, subperiosteal abscess, as well as a foreign body when the orbital cellulitis originates from a trauma. Whereas most cases of preseptal cellulitis can be adequately treated with oral antibiotic therapy, intravenous antibiotic therapy is required for all cases of orbital cellulitis, and this is very important to remember. And older patients will also require an anaerobic coverage because orbital cellulitis in older patients can be polymicrobial. Drainage of associated sinusitis and drainage of orbital abscess will also be required, and a transnasal endoscopic approach is sufficient for medially located abscesses, whereas an external approach will be required for orbital abscesses in other locations. Necrotizing fasciitis is an infection of subcutaneous tissues, usually along superficial and deep fascia, and it is a potentially vision-threatening as well as a life-threatening infection. However, mortality with orbital necrotizing fasciitis is less than with necrotizing fasciitis in other regions, and it is usually due to group A Streptococcus hemolyticus bacteria, but can be due to other gram-positive and gram-negative aerobic and anaerobic bacteria. And most patients with necrotizing fasciitis are immunocompromised. Initially, a necrotizing fasciitis can present like preseptal or orbital cellulitis and cannot be distinguished from them. However, soon symptoms and signs develop which suggest necrotizing fasciitis, and these include disproportionate pain, rapid progression, skin changes such as reddish or bluish discoloration of the skin, bully formation in the skin, or necrosis of the skin as seen in this picture. There will be sensory changes over the involved area, and patient can rapidly develop a shock-like syndrome with hypotension and multi-organ failure. Treatment of necrotizing fasciitis should be urgent, and debridement with intravenous antibiotics is indicated. However, debridement may not be required in well-defined involvement restricted to the eyelids. Broad-spectrum antibiotics are instituted, and among broad-spectrum antibiotics which can be instituted, clindamycin needs special mentioning because not only it acts against most causative organisms but can also neutralize the toxin of group A beta hemolytic streptococcus. Mycobacterial orbital infections are usually unilateral and occurs in children, and they can present with involvement of bone, soft tissues and or the lacrimal gland, and being indolent it can masquerade as orbital malignancy. So mycobacterial orbital infection comes in the differential diagnosis of orbital malignancy, and orbital involvement with mycobacteria is usually due to hematogenous spread from a pulmonary focus and is less commonly from adjacent tuberculous sinusitis. Clinical features of mycobacterial orbital infection includes proptosis, motility dysfunction, and also includes bone destruction and chronic draining fistulas. Diagnosis is by histopathologic examination showing caseating granulomatous inflammation typical of tuberculosis, but acid-fast bacilli are rarely isolated, and treatment of orbital tuberculosis is with anti-tubercular therapy. Among fungal orbital infections we have mucormycosis and aspergillosis, and mucormycosis is also known as phycomycosis or invasive fungal sinusitis, and is a very important entity to understand. It is the most common and most virulent orbital fungal infection and is caused by mucor or rhizopus, which are non-septate fungi, and the infection originates in the nasal cavity or a sinus, and from there it spreads to the orbit. Characteristically, these organisms invade blood vessel walls, causing thrombosing vasculitis, resulting in ischemic necrosis which promotes further fungal invasion. And mucormycosis occurs in patients with predisposing conditions, including metabolic acidosis, particularly diabetic ketoacidosis, which is very important to remember, patients with malignancies with poor white cell function, and patients on immunosuppressive therapy following organ transplantation. So in patients with these predisposing conditions, a presentation of orbital cellulitis should be first considered to be mucormycosis unless proven otherwise. Clinical features which develop in rhinocerebroorbital mucormycosis include necrosis of eyelids, necrosis of the scalp and necrosis of palate with black eschar formation. And here we see a picture of a patient with black eschar formation on the palate. However, because of the ischemia, inflammation may be minimal. But there is rapidly progressing proptosis and ptosis, and patients with mucormycosis can have central retinal arterial occlusion, orbital apex syndrome with ptosis, ophthalmoplegia, decreased vision, and sensory loss in the territory of the first division of the fifth cranial nerve, cavernous sinus thrombosis, which in addition to all the signs of orbital apex syndrome will have sensory loss in the territory of the second division of maxillary nerve, and mucormycosis has a significant morbidity and mortality from CNS invasion. As we have mentioned, a very high degree of suspicion is important in an appropriate clinical setting, that is, a patient with a predisposing condition such as diabetic ketoacidosis. However, imaging findings may be deceptively mild in mucormycosis, but tissue biopsy shows non-septate hyphae which stain with hematoxylin and eosin. Treatment of mucormycosis includes correction of underlying condition, which is very important and may actually determine survival of the patient. Wide surgical debridement, which is always done in mucormycosis, which can be an exenteration. Antifungal therapy with intravenous with or without retrobulbar amphotericin B, and hyperbaric oxygen. So correction of underlying condition, wide surgical debridement, and antifungal therapy, all three are required for adequate management of mucormycosis. Aspergillosis of the orbit occurs in several forms. We have invasive aspergillosis, which presents as a fulminant sinusitis secondarily involving the orbit with severe pain, proptosis, and decreased vision. And tissue biopsy shows septate hyphae which stain with GMS, that is Gomorrhea methenamine silver stain, and this requires extensive debridement with intravenous amphotericin B therapy. Chronic necrotizing aspergillosis is less fulminant and more indolent, but still causes destruction of sinuses and adjacent tissues, and can have intraorbital and intracranial invasion with significant morbidity. And there is also a non-necrotizing form of chronic aspergillosis, where we find tightly packed balls within the sinuses, but with absence of inflammation and absence of bone destruction. And there is an allergic form of aspergillosis which presents with chronic sinusitis, and patients have peripheral eosinophilia, raised immunoglobulin E, and raised fungus-specific immunoglobulin E, and it is characterized by thick mucin accumulation in the sinuses, and sinus biopsy shows eosinophils, thick peanut butter-like mucus, and extramucosal fungal hyphae. And this entity is treated with endoscopic sinus drainage and debridement. However, 20% of these patients may have orbital involvement. Among parasitic orbital diseases, we have cysticercosis, which is caused by pork tapeworm Tinea solium, and it usually involves extraocular muscles. So we find this cyst in medial rectus muscle of the left orbit in the CT scan of this patient. And cysticercosis in the orbit usually responds to albendazole and steroids. And this is in contrast to intraocular cysticercosis, which should never be treated with antihelminthics. Hydatid cyst is caused by dog tapeworm Echinococcus granulosus. And here we see a picture of an hydatid cyst in the right orbit. And hydatid cyst needs surgical excision because rupture can cause severe inflammation. Trichinosis is caused by Trichinella spiralis, and it causes inflammation of the eyelids and extraocular muscles. Herpes zoster ophthalmicus can involve the orbit and can result in proptosis and orbital apex syndrome. Thank you for listening.